So as you heard, I am from the Medical University of South Carolina, where we have the highest per capita rate of COVID-19 infections in the United States right now. So at the moment, it would be my advice to my partners to treat appendicitis and cholecystitis with antibiotics. And why would I say that? Because there's a risk to the patient of respiratory failure, progression with intubation. There's a risk to personnel of transmission during the intubation. There's a risk of transmission to other patients while those patients are being transported to the OR and the PACU, where there are other patients cohorted. There's a risk of resource constraints, not just PPE, but the OR personnel, as you already heard. And I would say that my evidence for this is that there is ample evidence that you can safely administer antibiotics for acute appendicitis as per the CODA trial, which was published this past year in the New England Journal of Medicine. You might have heard of it. And then there's also the Tokyo guidelines by which we can administer antibiotics for the treatment of acute appendicitis as an accepted form of therapy. I would also say that we also did a retrospective multi-center study during the pandemic and determined that instead of what we hypothesized, which was that the severity of appendicitis was going to be much worse in our institutions because we were delaying appendectomy because patients were staying home and avoiding the ER, we actually saw that the rate of appendicitis went down in all 6 centers that we looked at, and the proportion of those patients that had severe appendicitis was lower. So in fact, there were probably a lot of patients that thought they had appendicitis at home and may have actually had appendicitis and never got antibiotics and actually got better. So we might actually be over-treating patients that present with acute appendicitis. That's all I have to say.
Thank you. Opening comments by Dr. Dino Spaniolas from Stony Brook University. As he's going up there, I will mention, he asked me earlier if I had a portable charger. I said, well, is your phone dead? And he said, no. And I said, well, why do you need a portable charger? And he said, well, I'm about to be charged with a battery. I didn't quite know. That sounded a lot funnier in my head. Dr. Spaniolas.
Can we vote on that joke?
I want to, yeah, if you, just for the joke alone, I deserve to be voted. So I'd like to thank the society and the chairs, program chairs, and session chairs for the invitation. I'm here to convince you that appendicitis and cholecystitis should be managed with surgery, and I feel like I have very little convincing to do. We all know from before COVID times that this is the best way of managing these disease entities, and it would be natural to think that's the same during the pandemic. You know, the hopeful purpose, like why to do non-operative management, would be to get those patients home so that we have more beds and resources to manage sick COVID patients. Unfortunately, non-operative management for these conditions fails to do so. The old school concept of let's cool off this gallbladder involves 2 to 3 days in the hospital with antibiotics. If you're lucky, you'll go home. If you're not lucky, you're gonna get a procedure with a drain. Then you go home, only to come back 4 to 6 weeks later for another hospital event. And sometimes there was another return to the ED in between. That is a lot of hospital use and a lot more than a day and a half, or oftentimes less, to go from the ED to the OR to home. In terms of appendicitis, I really enjoyed that New England Journal of Medicine manuscript, which shows that patients who got antibiotics had the same length of stay with patients who had surgery, but they were 5 times more likely to be readmitted over 90 days. I think that is a lot of hospital use. So if I were to summarize, it is very clear that non-operative management, all it does, it kicks the can down the road. The patient goes from the ED to home. They come to my clinic crying. Then I send them back to the hospital. Then I have to do their surgery. It increases length of stay, hospital utilization, which could be detrimental about how a hospital manages their entire population during the pandemic. Thank you.
Thank you. We'll now have, well, we can hold our applause because we're going to have 2 rebuttals, one by Dr. Evans and then again by Dr. Spaniolas.
So I really appreciate that Dr. Spaniolas read the article, but I don't think he read it correctly. The CODA study actually allowed patients to be admitted after they received antibiotics as their first treatment for appendicitis. But as the study went on, there were increasingly numbers of patients that were discharged from the ED to take their antibiotics PO at home. And so what it demonstrates is that maybe you wouldn't effectively treat 100% of the patients with acute appendicitis, but you would delay, you would allow those patients to be able to leave the hospital immediately, and only about a third of those patients in the first 2 years follow-up would have a recurrent appendicitis. You also said that we should treat patients the same during the pandemic, and I completely disagree with that. We can't treat patients the same during the pandemic. We have to test patients for COVID. We have to know that they're COVID negative. We have to protect our healthcare workers, because we will have even fewer resources in the following days after somebody converts positive and they aren't able to come to work, even if they aren't sick. So I think it's really disingenuous to say that we should treat patients the same. We cannot do that with the resources that we have. And then finally, I would say the acute cholecystitis, you wouldn't necessarily have to keep those patients in the hospital for weeks. I don't think that that's the case. And I think that it's important for us to at least try to get patients home as early as possible. And when we don't have the resources to use the operating room, this is a viable option for us.
Thank you. Dr. Spaniolas, any follow-up comments?
So first, in terms of cholecystitis, the Tokyo guidelines mention that surgery is the by far best way to treat the overwhelming majority of patients who can tolerate surgery. And that's why it is common practice. Second, most patients who come into the hospital with these conditions don't have COVID. So as long as they don't have COVID, it's trying to figure out, well, what is best for them, and how can we let them not be a victim of COVID when they don't actually have COVID. And then finally, antibiotics can last for 2 to 4 weeks, but the pandemic lasts for a lot longer. And somehow we have to figure out a way to get those patients the care they deserve. Thank you.